Good evening and hello, everybody. Thank you for joining for today's webinar where Dr. Sylvester is explaining the benefits of enhanced lung function assessment in early respiratory diagnosis. So if you have any questions, feel free to ask them in the chat box that you have on your right-hand side of the screen. And we will try to answer them at the end of Dr. Sylvester's presentation. So welcome and thank you very much for attending the webinar.
Great. So thank you very much for the invitation to speak to you today on the topic you can see on your screen here. So early respiratory diagnosis and the benefits of an enhanced lung function assessment. So my name's Carl Sylvester. I'm a physiologist working in Cambridge in the United Kingdom. And what I'm going to talk to you about this afternoon or this evening are a couple of points. Firstly, where the evidence has come from for this claim. Secondly, how we do a more enhanced lung function, what's the process behind it, some of the theory behind it, and then hopefully a little bit more evidence as to why enhanced lung function would be a good idea as a first port of call when looking at early respiratory diagnosis. So much emphasis globally is placed on the performance of spirometry in a community setting, and it's there as a means to try and achieve an earlier respiratory or other diagnosis. And certainly within the UK, our healthcare system and our healthcare professionals, the NHS, have suggested that spirometry performed in a quality assured manner will increase the detection of respiratory disease. And certainly spirometry has many benefits and will do as they suggest. However, I do feel that there are other potential opportunities to improve it even further. So this graphic here is something that we would tend to use if we were looking at cardiopulmonary exercise testing, but hopefully it demonstrates how spirometry and detection of breathlessness, maybe as a symptom using spirometry alone, is limiting what we're able to detect. So if we think about oxygen getting into the system and getting to the cells for respiration, we have obviously it needs to get into the lungs, but once it's in the lungs, it needs to get across the alveolar capillary membrane, into the pulmonary circulation, into the cardiovascular system, across the blood and muscle barrier, into the mitochondria for energy production. So you can see that there's a number of pathways, a number of instances along this pathway where if a patient is presenting with breathlessness, that there could be something that's not quite right that we may need to be able to investigate. And spirometry on its own is going to detect most things that are going to happen within the airways, looking at airway patency, but it's going to miss some of the other potential causes of the patient's presentation with their symptoms. So in our practice, anecdotally, we knew that there were a number of patients that presented to our department who had normal spirometry but abnormal gas transfer. Now, what we didn't know was what the extent was of this and did it really make much of a difference. So we wanted to look at our current lung function database to determine what the instance was of patients presenting with normal spirometry but abnormal gas transfer, because obviously this has implications for achieving that goal of an earlier diagnosis. So in terms of the methodology for the study, we retrospectively reviewed all patients that were referred to our department for their first respiratory diagnostic assessment from June 2006 to December 2020. And with all of the data, we assessed them via the GLI reference equations to determine what normality was. And we assigned normality on spirometry as being an FEV1 FVC ratio of greater than 1.64 SRs or Z scores. That would confirm that they didn't have an obstructive lung function abnormality. and then an FVC of greater than minus 1.64 SRs or Z scores to confirm that there was no suggestion of a restrictive lung function abnormality. And then when we were investigating the gas transfer measurements, both TLCO and a KCO of less than minus 1.64 standardized residuals confirmed the presence of a gas exchange abnormality. Now, unfortunately, at the present time, the GLI reference data set for gas exchange, we had to exclude some of the patients because they are not valid in non-Caucasian patients, and they're also not valid in patients who are older than 85 years of age. So if we look through the cohort of the patients that we investigated, we started off with just under 28,000 first visits. And then once we'd excluded the non-Caucasian patients, those older than 85 years, and those in whom there wasn't any gas transfer measured, we ended up with just over 17,000 gas transfer spirometry measurements for their first visit. Once we excluded just over 4,000 patients who we detected as having abnormal FEV1 FVC ratio, so suggestive of obstruction, and those with an abnormal FVC, suggestive of them having a restrictive abnormality, we ended up with just under 13,000 first visits with normal FVC and spirometry values. And amongst that cohort then, we identified that just under 40% of those patients presented with an abnormally low TLCO, so the total lung transfer for carbon monoxide, and about 26% presented with an abnormally low KCO. And if we break that down a little bit further, so of those that presented with an abnormal total lung gas transfer abnormality, just over 3,000 of those also had an abnormal KCO. And of those, 2,029 had an abnormal alveolar volume. 937 had abnormal everything, so TLCO, KCO, and alveolar volume. And there was 262 that had an isolated low KCO value only. 45 of those also had an elevated alveolar volume, whereas the remainder all had normal alveolar volume measurements. So hopefully clearly demonstrating that there are a proportion of patients that present for their first diagnostics with abnormal gas transfer. And we weren't able to break down those results into what the subsequent identified disease was, but in terms of why they were referred to our department, the vast majority were referred with either query or suspected COPD, asthma. There were some rheumatology patients, hepatology patients in there, so some patients coming for liver transplant assessments as well. So then just thinking about how we would introduce gas transfer into a diagnostic pathway, certainly earlier on. In the UK particularly, we have a patient representative organisation called the British Lung Foundation, and they had put together this task force for lung health. The aim of the task force being to identify how respiratory disease can be identified earlier as one of their targets. And people or groups and organisations that were part of this task force for lung health included patient representatives, healthcare professionals, industry partners. And the idea was that there would be lobbying of government to try and improve respiratory disease identification within the UK. And as part of that, developed this diagnostic pathway for patients with symptoms of lung disease. Now, you can't see the detail on there, so I'll just expand a part of it. And what you can see as part of that pathway is having diagnostic tests within a hub, assessment of their heart, respiratory, and mental health by a multidisciplinary team. But importantly, and all credit to the task force for lung health, before the evidence that I've just presented was available, they actually included a gas transfer measurement as a kind of a first line assessment if patients are presenting with suspected respiratory disease. So if we're thinking about generating a pathway that includes gas transfer, it is possible, and it's already in the pipeline, certainly within the United Kingdom. And so off the back of that, we thought about what the benefits in addition to diagnosis would be, and so a reduction in a protracted diagnostic pathway would be obviously a benefit if we're identifying that they have a gas abnormality earlier. The danger with spirometry, just doing spirometry alone, is, as you can see from the evidence, potentially 30 to 40 patients continue on a pathway of unknown diagnosis for a little bit longer. So if we can reduce that by including gas transfer in the pathway, that would be a help. And then on the back of this, not knowing that they have an abnormal gas transfer may mean that there's unnecessary trials of medication to try and alleviate ongoing symptoms. Obviously, there's time and healthcare economy implications there. Again, reduction in unnecessary referrals if we already know that there's an issue. Reduction in other non-essential diagnostic procedures, and then a reduction in the number of consultations to primary care with ongoing symptoms without actually knowing what the problem is. And I'm not saying that would, including gas transfer in the pathway, would solve all of those problems, because there would still be others, but we're reducing those issues. So how to do it, and unfortunately we've tested the audio on this, and the audio isn't working, so I'm going to speak to you over this video. So what you can see on this video is I'm talking to the patient, I'm instructing them how to do it, and it's really important to take the time instructing the patient how to perform a gas transfer measurement, so they're aware of what's expected. So just explaining to them that I'll be asking them to breathe normally, breathe out as far as they can so they can't breathe out anymore, and then to take a big deep breath in until they're full, and at that point they'll be inhaling a couple of different gases, which I'll talk through a little bit later on in the presentation. They hold their breath for about 10 seconds, and then after they've held their breath, they breathe back out into the machine until we've got a measurement. So you can see patients on the mouthpiece with a bacterial and viral filter. They're wearing a nose peg. They're breathing normally in and out on the machine to start with. And in a second, I'll be instructing them to breathe in, breathe out to empty as far as they can go, all the way down to the bottom. Now, just note the date of this video. It's 2009, so this is pre-rapid gas analyzer testing. So big deep breath in, hold the breath. We have a counter, counts down for about 10 seconds. No leaks, and then after the breath hold time, they breathe back out into the tube. We take a sample of the gas. They come off the tube, take the nose pegs off, and then on the old systems, we would wait a minimum of 4 minutes before going any further. So that's how we would perform a gas transfer measurement. I guess the other thing to note here is look at the size of the equipment that we use in secondary care. It is quite large, but there are systems available that can be used out in the community that are no bigger than kind of a portable TV at the moment, plus a gas cylinder. So it is possible to do such a test like this in a kind of a relatively mobile situation. Or in the UK, we're developing diagnostic hubs, and so having a system like this would fit quite well within a diagnostic hub. When you're making the measurement, there are things that will affect the outcome. Some of those will be pathological, some of those will be physiological, some of those will be things that the patient will be requested not to do before they come to the exercise test. Sorry if you can see that, I'm going to postpone it. So exercising before, we don't want them to do. We don't want them to have sort of eaten a meal, and then things that can change the test that they may do is a Muller maneuver, where they're trying to inspire against the closed tube. We don't want them to do that. Or Valsalva maneuver, where they're trying to blow out against a blocked tube, because when they hold their breath, the tube is physically blocked off, so they can't breathe in or out through it. What we don't want them to do is try and make a maneuver against the tube that then may impact on the assessment that we get. And so you can see on there the different things that will either increase the gas transfer measurement or decrease the gas transfer measurement. And we'll talk about some of the diseases that impact it a little bit later on as well. So in terms of the measurement, and what you would have seen from the video that I've just demonstrated there, is on the old systems that weren't rapid gas analyzer systems, that I imagine there are still systems out there that do it this way. What we're showing here is a volume increasing on the y-axis, time increasing on the x-axis. So at this point, the patient has breathed out as far as they can down to residual volume. They take as big a breath in all the way to the top, and the new guidance in 2017 stated that the inspiratory effort had to be completed within 4 seconds, but the quicker they can do it, the better. The inspiratory volume needs to be within 90% of their maximum on any of the other tests that you've made. And then there's a period of a breath hold time here while they're holding their breath and the gases are mixing within the lungs and transferring across into the pulmonary capillary system. Once the time frame is ended, they then breathe back out. Because we have a volume within the lungs that is dead space, we have a washout volume, so that hasn't been a part of any gas exchange. And then there's a sample volume. As I say, this is the old style analyzers, the slightly slower responding analyzers. If we look at what we get with some of the new rapid gas analyzer systems, you can see that we've got a tracer gas. On the old systems was helium, on the newer systems is methane, and on both the old and new systems, carbon monoxide is also inhaled. And you can see the gas is introduced into the system as soon as the patient inhales. They hold their breath, they breathe back out again. The tracer gas goes down to a point of a plateau, and the carbon monoxide drops down as well, doesn't reach a plateau because it's continuously being transferred across into the bloodstream. And so how the gas will get from the lungs across into the bloodstream is dictated by this fixed law of diffusion. And it's basically that the transfer of a gas takes place down a partial pressure gradient. And there are certain things within the lungs and the airways that will impact the ability for the gas to get across into the pulmonary circulation. And so the flow of a gas from one part to another is directly proportional to the surface area available to gas exchange, and also the diffusivity of a gas. I'll come back to that in a second, and is inversely proportional to the thickness of where the gas needs to go from one place to another. And it's also driven by the partial pressure difference in the gas from one side to the other as well. So just coming back to the diffusivity, and you'll notice that we're using carbon monoxide to assess gas exchange rather than oxygen. And if we think about how the solubility of a gas, so the diffusivity is related to the solubility against the molecular weight of a gas, and obviously the molecular weights of oxygen and carbon monoxide are fairly similar, oxygen being 32 and carbon monoxide being 30. So one reason why carbon monoxide is a good gas to utilize for this test. So things then in terms of pathologies that can influence the outcome of the measurement. Obviously, if we don't have the surface area, and as we can see from that fixed equation, because area is proportional to the ability for the gas to flow across, if we have a thicker area that it needs to transfer across to or from and to, then that's going to reduce the ability of the gas to get across. So an example of this would be an emphysematous lung disease. So we can see on the left electron micrograph here of a normal lungs, and you can see the alveoli, lots of alveoli, lots of space, lots of surface area for gas exchange to take place. Whereas if we look on the right hand side, we've obviously got that destruction of elastic tissue within the airways that means we don't have as many alveoli, and those that are there are very wide and big. We talk about going from, say, alveolus of like a bunch of grapes going to quite a floppy balloon, and obviously that massively reduces the surface area that's available for gas exchange, and so we'll see a low gas transfer in patients with emphysematous lung disease. If we look then at something else, so the thickness of the membrane, which is inversely proportional to the flow of a gas, obviously then the increased thickness will cause a reduction in the flow of a gas across from one part to another. And if we think about a disease where this could be impacted, it would be interstitial or fibrotic lung disease. And again, if we compare what we see under an electron micrograph of the lungs, the left being all of those nice multitude of alveoli and alveolar walls, whereas with fibrotic lung disease, we're getting a lot thicker tissue and interstitial space in the alveoli. So that increased thickness then is going to reduce the ability of the gas to get across into the pulmonary circulation. Other things that can affect the ability for oxygen or any gas that's soluble to get from the lungs across into the bloodstream is the availability of haemoglobin. And so within the pulmonary circulation, the pulmonary capillary blood volume is limited to about 70 mils. Obviously, this will change dependent on the size of the individual. And it's at rest, average residence time within there about 3/4 of a second. And for the oxygen to get across, it transfers by diffusion, and it's taken up into the haemoglobin by diffusion. And the ability for oxygen to combine with haemoglobin is enhanced by the red blood cell having a large surface area, mixing well within the plasma, and that the red blood cell is able to change its shape to make sure that its contact with the alveolar capillary membrane wall is maximum. So thinking about the theory behind limitation to gas transfer, and a couple of pictures here that taken to allow you to look at some of the considerations. So if the lungs are fine, and if the ability for the lung to transfer gas is fine, which would be indicated by this large coal chute here, what we're then limited potentially by is the coal carts coming through and leaving. So if we obviously have a reduction in perfusion, then oxygen's getting across, but there isn't enough oxygen carrying capacity within the blood, and that can cause a reduction in gas exchange, which would then be perfusion limited. However, if we have a problem with the ability of the lungs to exchange gases across into the pulmonary circulation, then we've got a reduction in transfer across, and then means that the coal chutes are leaving the pulmonary circulation without being optimally saturated with oxygen. So then this becomes a diffusion limitation. So we can correct, so if haemoglobin within the individual is not where we would expect it to be, then there are equations available for us to be able to correct for the haemoglobin concentration within the blood. And you can see here there's one for adolescent and adult males. There's a different one for children that are less than 15 years of age and for females. And we can use those as a correction factor if we have somebody who's anemic and that's the only reason that their gas exchange appears lower. It will correct it back up to what we would expect it to be for a normal haemoglobin level. And so if we think about haemoglobin levels at a level of 6-7 grams per deciliter, there's about a 30% reduction in DLCO or TLCO and KCO. And so that equates to roughly a 4% reduction for every gram of haemoglobin lower. However, what we just have to be careful of is sometimes severe anemia can be accompanied by a rise in cardiac output, and then sometimes these equations may overcorrect. And just to come back a little bit to why carbon monoxide is used rather than oxygen. So CO resembles oxygen in a number of areas, as I mentioned before. Its solubility, its molecular weight, and its ability to reversibly combine with haemoglobin. But where it has an advantage is that it has about a 200-250 greater affinity for haemoglobin than oxygen does. So it makes it a very good gas at being able to identify any diffusion components. So using Fick's law then and just rearranging the equation so that we actually get the measurement that we want, which is the diffusing capacity of the lung for a given gas, we just rearrange the formula. And what we end up with is that the diffusing capacity of the lung for any given gas is the quantity of the gas that can be transferred, and it's by unit time and per unit pressure difference from the alveolar side to the mean capillary side. So that is actually what we're measuring. And the systems will make all of these calculations, but it's important to understand how they're done, because you can make adjustments in the system if you wanted to. So I think for a while it was mistakenly assumed that we were measuring the TLCO, or the total transfer of carbon monoxide for the lung, but what we're actually measuring is the KCO, or the permeability factor, and then the alveolar volume, and we're multiplying then KCO by alveolar volume to give us the TLCO. So there's the equation there, but it's probably easier to show you on the graphical representation here. So on the left hand side we can see we start with concentrations of, in this instance, helium, but on the new rapid gas analyzer systems it would be methane. So we start with these two gas concentrations. The patient then breathes out. They've held their breath, they then breathe out. Both of the gases start to drop, and what's happening here is just dilution of the gases within the airways, and the dilutional effect of helium is telling us a couple of things. It's telling us what the available volume of gas there is within the lungs for gas exchange, but it's also telling us how much of the carbon monoxide is getting diluted within the airways as well, because we don't want to include that within the calculation. So then once we get to a point where we see a plateau in the tracer gas, we then measure the slope of the gas concentration at that point for carbon monoxide, and somewhere along this slope we take a point, and we know that that slope is the KCO value, so the permeability factor available for lung gas exchange, and then that's how we work out what the diffusion or transfer capability of the lung is for a given gas. On the new rapid gas analyzer systems, you can see that we have a plateau. We also get the drop off, and you can adjust these now. If you don't think that we've quite reached the dilutional effect, you can shift them across if that works. So thinking about interpretation strategies, this is I'm sure many of you will have seen this. This is the interpretation algorithm from the 2005 guidelines. I understand that there's some new interpretation guidelines due shortly, and so what we can see here is they're working from a point of spirometry, working their way down, and then determining if the DLCO is low or not. Then these are the different disorders that could be presenting in terms of spirometry and gas transfer. And then just some other examples of where gas transfer can be useful in monitoring for disease. This is some research that we presented at the ERS a few years ago now, but it was looking in patients with alpha-1 antitrypsin deficiency and how the disease was progressing. And what we found was that the groups were fairly were split up into 4 distinct groups. There was a small percentage that had no decline in either their spirometry or their gas transfer values. Just under 20% that had a decline in FEV1 only, about similar but just over 20% who had a decline in gas transfer only, And then about 55% who demonstrated decline in both FEV1 and KCO, so demonstrating the utility of gas transfer when you're monitoring disease progression. This study, it's an early view on the European Respiratory Journal, but this team looked at how lung diffusion was impacted in adulthood following patients who were born prematurely. So this was groups of patients born between either 1982 to 1985 or 1991 to 1992 that had a gestational age of less than or equal to 28 weeks or a birth weight of less than 1 kilogram. And they compared their values to matched controls. And so what you can see is that for the 91 to 92 cohort, they measured them once when they were 11 years of age, and then once again when they were 18. And for the 82 to 85 cohort, they measured them at 18 and then again at 25. And these are all measurements in terms of Z scores for DLCO, alveolar volume, and KCO. They also managed to distinguish membrane diffusion capacity and pulmonary capillary blood volume by getting the patients to breathe in utilizing 2 different oxygen concentration methods. And what you can see is that for all of the gas transfer measurements, they're consistently lower in the prematurely born individuals compared to their matched term-born controls, but that the alveolar volume was not significantly different. So for DLCO and KCO, there was a significant difference between the groups, but there wasn't a significant difference in their volumes, which is quite interesting. And if we're thinking about looking to the future with lung disease, so gas transfer can be a useful prognostic indicator, and in this study from colleagues at Royal Papworth Hospital, what we can see is that in patients with IPF, their baseline lung gas transfer alone, when compared to other lung function measurements, was best associated with survival. So the lower the baseline lung gas transfer, the lower the survival in terms of number of days. And again, as a kind of a prognostic indicator, again, we're looking at percent survival on the y-axis and time in months. And we can see that those who had the greatest decline in gas transfer between measurements, so those with a greater than 15% decline in gas transfer, showed the worst prognosis, worst survival. So hopefully further identifying the ability of gas transfer and including gas transfer in your measurements as being quite useful. So I hope that's given you quite a run through of gas transfer, why we utilize the measurement, why we feel that it's an important measurement to include, and certainly why it's useful from a community perspective. And obviously very happy to answer any questions that anyone may have.
Thank you very much for the great presentation. I will just look what kind of questions came in. There's one question from Martin Bocknell, and he's asking, how do you think quality gas transfer can be measured in a community setting?
Yeah, good question, and hello, Martin. Well, certainly within the UK, we have good standards for the performance of spirometry. My feeling and suggestion would be that we would transfer the excellent outcomes that we have from the training that we deliver through our profession and professional body to utilize that for gas transfer measurements as well. don't know whether Martin would agree, but spirometry and gas transfer are, in terms of resource intensity, fairly similar. And I think if somebody can be trained to quality assure perform spirometry, then they should be able to be trained similarly to perform gas transfer.
Thank you very much. There's another question from Shirley Coelho. I'm hoping I'm pronouncing the names right. I'm sorry for that. How easy would it be to set up a system to measure DM and VC? So I mean, it's vital capacity and diffusion capacity, I think.
So I think it's to do with what the premature study looked at, which was the ability to differentiate between membrane diffusing capacity and pulmonary capillary blood volume. Of course, with gas transfer measurement using carbon monoxide, you can't really distinguish between the two. But there are systems available, and funnily enough, was just having a conversation with one of the manufacturers today that you can either utilize, as that study did, 2 different oxygen concentrations, which would allow you to work out membrane diffusion and pulmonary capillary contributions. But there's gas transfer using nitric oxide as well. And what you do is you perform a gas transfer measurement with CO and nitric oxide, and by having the 2 measurements performed at the same time, it allows you to then distinguish between whether it's a membrane diffusion problem or a pulmonary capillary volume problem. So it is possible to do. There are systems on the market available to do that. Speaking to the manufacturer earlier, they don't have it on their new systems because the demand for it isn't there. But if the demand was to increase, then they would certainly look at adding that to their current portfolio of systems that they provide.
Thank you very much. There just came some further questions. So Anoop Nambiar is asking, what are your thoughts about DLVA? So I think that's KCO values. In what patient would this be useful? And in ILD patient, it is often stable while the patient is declining with a falling DLCO.
Yeah, so it's important to distinguish between the DLCO and the DL over VA or the KCO, because you know, in interstitial lung disease or IPF, the reason the DLCO is probably falling is because of a loss of volume. But I think it's important also to not forget that the KCO is also very important to look at. Is it a volume problem, or is there actually something going on with the interstitium? So I know a lot of studies, and certainly the studies I presented was looking at DLCO or TLCO, but it is important also to look at the KCO, because if the KCO is obviously low, but the VA is normal or doesn't quite equate, then that's obviously telling you something about the ability of the lung to exchange gas, rather than it just being an alveolar volume problem or a lung volume problem. So it's a very important test, and I think it's underutilized. I don't think many people sort of utilize the KCO enough. The TLCO seems to take precedent, but the KCO is very important, as I say, to distinguish between whether it's a volume related effect or whether it is a true diffusion problem.
Thank you. There's one more question from William McConnell. Who will be interpreting the results for primary care and putting it into a clinical context?
It's a great question. It probably in some respects comes back to the answer to the first question around training. You would hope that you could train. You know, we obviously train community clinicians to interpret spirometry. I would hope it wouldn't be beyond the realms of possibility to allow them to interpret the gas transfer, but I guess if you've identified that there is a gas transfer problem, you would then maybe be thinking about referring into secondary care anyway. And where we'd be talking about an earlier respiratory diagnosis, okay, they may still need to come into secondary care, but they'll be coming into secondary care a lot sooner. So the pathway to diagnosis and potentially life-preserving interventions will happen a lot sooner.
All right, great. There are no more questions around. Probably they are, but no one put it here into the question box. I think if you don't have anything more to add, we can close the webinar.
Yeah, all I would say is that if people do think of questions afterwards, then I guess they can contact you, can they? And then you can forward them on to me.
Yes, of course. So you can contact us over contact@ndd.ch every time, and the questions then will be forwarded or answered by us. Exactly. Yeah. So I would thank you for your time, especially thank you, Dr. Sylvester, for your very great presentation and taking your very, I think you don't have much time, but thank you for taking the time for us and the webinar. And thank you for everyone who joined us today. And I would say probably until next time. Have a good evening, everyone.
Thank you.